Good evening, everyone. A very warm welcome to all as we come together to celebrate C Kohli Day at CDiTH Hyderabad. Today marks the 101st birth anniversary of C Kohli and the 5th year of our celebrations in his honor at CDiTH. It is an absolute pleasure to have you here for this special occasion. We are especially honored to welcome our esteemed chief guest and keynote speaker, Dr. Nageshwar Reddy. At the heart of CDiTH Hyderabad's innovation ecosystem lies the Kohli Center on Intelligent Systems, KCIS, a hub where cutting-edge AI and machine learning research comes to life. Established with a vision to push the frontiers of intelligent systems, KCIS is not just about algorithms and data, it's about shaping the future. From deep learning breakthroughs to real-world impact, KCIS thrives on curiosity, collaboration, and excellence. Here, scholarly minds turn ideas into impact, driving India's AI revolution. To set the stage for today's celebrations, I now have the privilege of inviting Professor Madhav Krishna, head of the Kohli Center on Intelligent Systems, to deliver the welcome address and provide the context for today's occasion.
Yeah, thank you. Just a brief intro of the Kohli Center and setting the stage. Yeah, the KCIS, or the Kohli Center for Intelligent Systems, was established through grants from the TCS Foundation as an umbrella center to foster research and innovation in AI and allied fields. The first phase of grants supported the development of brick and mortar infrastructure, including this very auditorium from which today's events are being broadcast. The second phase focused on catalyzing ambitious, interdisciplinary, and unconventional research projects. KCIS houses individual research centers dedicated to computer vision, language technologies, cognitive science, data science and analytics, robotics, machine learning, and computational social science. Each of these centers operates with its own mission and funding, securing support from both government agencies and private industry. KCIS holds a leading position in several areas, including computer vision, robotics, and machine learning, ranking #1 in India and amongst the top 20 in Asia. Every year, Kohli Day, coinciding with FC Kohli's birthday, is celebrated to honor the founder of TCS and the father of the Indian IT industry. Over the past 5 years, this event has featured high-profile keynote speakers and interactive sessions, including Padma Vibhushan Vishwanathan Anand on AI in chess, Devi Parekh, Research Director at Meta, Rajiv Rastogi, Vice President of ML at Amazon, Mausam, Professor at IIT Delhi and founding head of Yardley School of AI, Satya Chakravarti, Distinguished Professor of Aerospace Engineering at IIT Madras and founder of E-Plane, which unveiled India's first flying taxi. Today, we are honored to welcome the most decorated and distinguished speaker yet, Padma Vibhushan, Dr. Dubur Nageshwar Reddy, Chairman of the Asian Institute of Gastroenterology. His groundbreaking contributions in this field have impacted millions of lives, and we eagerly anticipate his insights on challenges and opportunities in AI and healthcare. Yeah, welcome, sir.
I'll just give the keynote.
You just go.
So I'll just announce you. Okay. Thank you. Thank you, Professor Krishna, for your insightful words and for setting the tone for this special occasion. It is an absolute honor to welcome a distinguished speaker whose contributions have redefined the field of gastroenterology, not just in India, but globally. Padma Vibhushan Dr. D. Nageshwar Reddy is a name synonymous with groundbreaking advancements in digestive health. As the chairman of Asian Institute of Gastroenterology and AIG Hospitals, Hyderabad, he has led pioneering research and innovations that have set new benchmarks in endoscopy and gastroenterology. Beyond his vast academic and clinical expertise, Dr. Reddy is known for his deep commitment to patient care, medical education, and pushing the boundaries of what medicine can do. His work has earned him global recognition, including numerous prestigious awards, and more importantly, the gratitude of countless patients and students who have benefited from his knowledge and mentorship. He has the unique distinction of being the first medical doctor in India to receive all 3 Padma Awards, Padma Shri in 2002, Padma Bhushan in 2016, Padma Vibhushan in 2025. In addition to these national honors, Dr. Reddy's contributions have been recognized internationally. He was awarded the Master Endoscopist Award by the American Society for Gastrointestinal Endoscopy, ASGE, in 2009, and the Rudolf V. Schindler Award, the highest award in the field of gastrointestinal endoscopy, in 2021. Today, we have the privilege of hearing from him firsthand. Please join me in welcoming the visionary and trailblazer, Dr. D. Nageshwar Reddy, who is going to give us annual lecture on Kohli Day. Thank you.
Thank you very much. At the outset, I'm extremely grateful to IIIT, Professor Narayanan and the group for inviting me here to give this talk. I'm also a bit nervous because when you told me the previous list of speakers were very distinguished, I don't think I fit into that booth, but so I was a little bit nervous, but also because I chose a topic which, why doctors don't like artificial intelligence. It's a little oxymoron coming to IIIT and speaking on a topic like that. I chose this for several reasons, and when I sort of looked at, as I usually do when I to speak on a subject like this, is not working? Which way? Oh no, he's changing it. No? Okay, let's try now. Yeah, so whenever I have a difficult topic, I go to ChatGPT, and then I ask ChatGPT, okay, I have this problem, what do I do? How doctors look at artificial intelligence? See, doctors have a mixed view. They have some positive views, but also there are several negative views, and these are the concerns and challenges. Trust, reliability, loss of human touch, data privacy, regulations, job displacement, and how are they trying to elaborate. So I have these topics, a summary of what I'm going to talk. In fact, that's not shown, but ChatGPT also told me that they can make some slides for me. But I said, in IIIT, they'll make out its ChatGPT slides. I can't fool the group here, so I didn't do that. So I'll talk to you only about the concerns the doctors have about artificial intelligence. Summarize what ChatGPT said. For most doctors, like my age group, AI is very complicated. Artificial intelligence is very complicated. For also, by the time I feel that by the time I retire, AI would only come after that, so there's not enough time for me to go into this. For the younger doctors, another problem. The problem is they're worried that they're going to be replaced by artificial intelligence. So these are the main concerns, and let me show you how we address this. So till about 5 years back, I was totally against artificial intelligence in medicine. I thought AI in medicine is not what we doctors are supposed to do. We are supposed to see the patient, give them empathy, diagnosis, do a certain particular group of tests, and treat them. That's the usual role of a doctor. And artificial intelligence had absolutely no role in this scheme of things. This changed for me in the last 2 years. In the last 2 years, especially the last year, I have actually become an ardent fan of artificial intelligence. In fact, I believe that artificial intelligence has a huge role to play, and I'm trying to convince our other doctor members that they should be doing it. Now, what changed my opinion was, I'd like to acknowledge people who changed my opinion. They're all here. We started a Department of Artificial Intelligence headed by Kinjal Saxena, and he's been educating me continuously in as much as my non-AI brain can absorb. Of course, Rakesh is here. Rakesh and GB have been very ardent followers of artificial intelligence for many years. I've been having wars with them saying AI is not going to be useful. But this group of people, once we started the artificial intelligence department in our hospital, actually convinced me that there has to be. And I'll show you how I got convinced because of this. So let's first start with the first one. AI is too complicated for doctors. It was for me. I didn't understand AI till actually Kinjal came up with this. He told me it's very simple. There are just 3 foundation models. There's a large language model, large or small. There's a computer vision model, and then natural language processing. That's all. You just know these 3 things is enough. And in medicine now, you combine these things together to get what we call a multimodal model. You combine all these three things, you get multimodal model. So we started working on this. I just got an impression, the mistake doctors all over the world have been doing is this. They've been concentrating on computer vision model. Somehow, the idea for doctors was that if you can identify something which a machine can identify, doctors can't identify, then it's something that's going to make a difference. So they started concentrating computer model. And we are all fascinated with dog or muffin pictures, you know. You show this, the computer is able to say what is dog. Sometimes we can't tell the difference, but the computer is telling. We are all fascinated with this, and that's how it came into medicine. And what happened also, the commercial interest came in, I think spoiled the whole AI in health category. So what happened was this, that using this convolutional neural network model, some of the companies started identifying polyps in the colon, and where even human eye can miss. The colonoscopy where this AI was put in was identifying the polyps. So this is what happened. And in United States, this is a huge business. The reason is they have what is called a compulsory screening colonoscopy. After the age of 50 years, every person in the United States has to undergo a screening colonoscopy to detect polyps. And if the polyp is detected, they immediately remove it. And this has shown to decrease the interval cancer in these people. Colon cancer incidence has come down dramatically. In some countries like Australia, if you don't get your colonoscopy done by 60 years, you have to pay a fine of $500 to the government. So this was a very strongly rooted screening cut went in. And these companies started with a thing showing that if you can detect polyps better than human eye, there's a huge amount of commercial benefit available. And then what they did was, as I said, I'm a gastroenterologist and I look at these polyps, and these are the polyps that we see. Some of these polyps can be missed by human eye, especially if they're very small. And Medtronic, a company which is probably the largest medical technology company, immediately started a system called Genius, MedGenius, which incorporated in the colonoscopy system, will pick up 20% more polyps than human eye can pick up. So what happened then was that every single endoscopy unit in the United States put in Medtronic with huge charges. They charge for running each endoscopy unit about equivalent 5 lakhs rupees per month. So you can see billions of dollars were involved and they pushed this. And they, of course, this was an example. My naked eye can't see this polyp very well, but this is pointing out. The computer is saying there's a polyp there, there's a polyp there, and that's how it was started. And some of these studies, this actually, China in fact went ahead. They are extremely ahead of us or rest of the world in artificial intelligence and endoscopy. And this was the first study, came from China, actually showing that if you put these intelligent systems into a colonoscopy, you can detect more polyps than in a routine eye can see. So naturally, I think all of you here would want to get a colonoscopy done only with a machine which has artificial intelligence, right? That's what because we don't miss them. And similar studies, in medicine, we do a lot of meta-analysis, and meta-analysis showed clearly that these polyps are going detected. But what was missed, the point was missed, and this is what I've been emphasizing from the beginning is, first of all, missing a polyp, does it translate into missing a cancer? Because in medicine, clinical outcome is more important. We're not bothered about whether you miss or not, whether it's not like engineering. In medicine, ultimately what happens to the patient, the clinical outcome. So whether we miss these polyps, does it make a difference? And second, putting in artificial intelligence, in addition to all this, does it have a disadvantage? Does it have a trade-off? So these two things people didn't see. Only now they're seeing it. One is that putting an artificial intelligence system into the colonoscopy, you're prolonging the colonoscopy time. You're actually taking much more time than normal. So that is making it a little more inefficient. Second is regarding translation to actual benefit. And this is very important. Again, this is a chart we use. So I just want to show you that most of the polyps that are detected by artificial intelligence, missed by human eye, are small polyps below the size of 6 millimeters. Now, it has been shown very clearly that if we follow these polyps do not turn into cancers. So there's no point in detecting them. You detect them, you take a biopsy, remove them, nothing happens. Whether you put it there or in other words, by extra detection, we are not giving additional benefit to the patient. The only person who is benefiting by this is the company. Medtronic, several companies, 6 companies came up, huge business for them, and they started pushing this. And unfortunately, when this happened and we realized AI does not have any role, doctors got disappointed, especially in the field of gastroenterology. We realized that we were taken up by companies. What is the role of AI? Should we actually pursue this further? And also differentiating one polyp from other malignant norm didn't make a difference at all. In fact, I thought this was huge technology. How do you detect polyp? How does the machine detect polyp? And I was discussing with Kinjal. In about a week's time, he came up with a local algorithm detecting polyp, costing nothing. So the companies took us for a big ride, made huge amount of money. And so what happened is, in general, the doctors got disappointed. They were disappointed that AI, when used in this commercial sense, didn't make so much sense. So that's to tell you historically what happened in this context. So what was more useful is this is simple technique. Now again, coming back to the colonoscopy colonic polyp example, we don't advise screening colonoscopy in our country. In India, we don't say above the age of 50 years, everybody should get a colonoscopy. 2 reasons. First of all, if everybody after 50 had to get a colonoscopy, we are finished. No gastroenterologist will have to work about 36 hours a day to finish that. That is one. Second, the incidence of colonic polyps, fortunately in the country, for whatever reason, is very low, less than 10%. Compared to 40% in Western population. So there's no point in screening the whole population at 10%, but this 10% are becoming important. So how do we segregate this 10% to do only screening colonoscopy in that? And this is where we used AI. This is Nitin Jagtap, one of our colleagues, who used, I don't understand this, gradient boosted tree technique for AI. I mean, most of you would be knowing this, is elementary. So use this technique to now screen. If you have a population of 100 people, using this technique, he said these 10 people require screening colonoscopy. And that's how we use. You see what's the difference of what Western world did and what we should do to actually use AI for more useful techniques. And this is something that we found extremely useful. The other area where AI is coming in is this. This is again very interesting. What is the time that I have? Okay. So it's, yeah, okay. So the other area is this, that in human cells, we have, so whenever people are getting bored, you can either sleep or walk off. Then I know it's I had to stop there. Okay. So this, you have in humans, say 30 trillion cells, when the 20,000 human genomes, 20,000 only. But we have in our body bacteria, which has got 2 million genomes, that our body is totally dominated by bacteria in the gut, totally. They're taken over, they do everything. We foolishly think that we are smart, we do nothing. Everything is done by bacteria. Whatever you eat, bacteria digest. Whatever you think, it's because of chemicals or bacteria. All our activities are totally controlled by bacteria. But we never knew how to study these bacteria because they couldn't be cultured. Nature has made it very difficult till these techniques came. We now have techniques, we can actually dissect and see all the 1,000 species of bacteria in our gut, right? But to do this, we require a lot of AI, a lot of computational science, we require bioinformatics people and so on. And this is where AI is helping us now to actually differentiate between this. So what is happening now is, for example, there are many companies in the United States, they say you send your stool sample, we'll send you a report of what is the microbiome in your stool based upon the genetic analysis of the microbiome. Now in India also, unfortunately, these companies are coming up. And patients come to me with a report like this. Now, how do I read this report? Because to me, it's all, I don't know. So now AI is being used to decipher this, and there are some good companies coming up. And this is a company called Jonah, which is offering you. So you send it to Jonah. Jonah uses AI and says, this is your GI health, this is your metabolic health, this is metabolic syndrome, this is your microbiome association, this is what you should do. So it tells you everything using AI. And this is where, again, in medicine is an example of how AI can be used intelligently, and this is something we are developing also in our institute rather than other ways, okay? So coming to the first problem of doctors not knowing about too complex, this is what doctors can learn AI. And the example is what we did. We set up course along with ISB. We run it every year, and Kinjal and Rakesh actually formulated that course where we teach doctors the course of how, what about AI. So if somebody old enough or stupid enough like me can learn a little about AI, everybody can. So doctors can now. Doctors have this course which runs, and they're actually making very good algorithms from this. I'll show you some of this. So the second question is, AI is not going to be used in my lifetime. That's what I thought. Say another 4-5 years, I retire, and then why do you have to learn all this? But this has changed dramatically, and I'll show you quickly 5 or 6 examples of what, again, Kinjal and his team have done in a hospital. Some of you have seen these examples, but they've changed this very dramatically. AI is now used. So again, I emphasize to doctors, don't think of AI only as a health problem. Look at AI as an operational relief for your hospital systems. And this is an example of Mira. Mira, some of you have seen. Mira is a medical informatic robot assistant that we made that is now trained like ChatGPT. Everything is talking. Mira talks.
Hello, everyone. I am Mira, the medical information robot at AIG Hospitals. I am your future healthcare companion, and here to change the way
what
we
we
think
did is
about
to cut
healthcare.
time short.
I have been meticulously designed to assist.
So what we did is we put Mira as a medical information robotic, so that when I see a patient now, normally what happens is I spend about 20 minutes with the patient, 10 minutes in actual talking, diagnosing, 10 minutes in explaining some non-medical stuff. They take this tablet 3 times a day and so on. All this is waste of time for doctors. Now Mira does all this, and now patients are getting used to, so after they see me, they'll immediately go and ask Mira, what should I do, any complications, tablets, and now they're preferring Mira because she's better at explaining and better looking than me. So they take Mira. So this is how now we're using this, and also we've fed a lot of medical stuff into Mira. So a junior doctor goes and says, Mira, what are the I did this endoscopy, this is a complication. She'll get you 5,000 articles of all the complications reported. The second thing, this is also very important, called iSave. This is something that we did, again, I think Mohan has seen some of these things in the hospital. iSave is something which is very remarkable. In a hospital, every day, we get what is called a code blue. 1,000 patients are admitted in all the beds, not in ICU, regular beds. And many of them are very sick patients. They crash suddenly. When they crash suddenly, what happens is immediately the nurse activates code blue. You got a call throughout the hospital, code blue. Code blue, we have a group of doctors who rush. They should reach within 4 minutes to save the patient. After 4 minutes, we can't save. So if we get 6 code blues in a day, only 3 we can save, 3 we cannot. This happens not only in our hospital, all over the world this happens. So what we found, again, thanks to Kinjal's team, that there are 7 parameters like oxygen saturation, pulse rate, BP and all, which are there in the standard nursing charts, which are entered normally, goes into the EMR. If a patient reaches 5 of these abnormalities, immediately it's likely that in the next 2 hours he'll go into code blue. So when he reaches 5, immediately the nursing staff, the medical emergency team is informed, they go there. And they go there and then they revive the patient before he crashes. And since this is started, we haven't had code blue at all. Which means every day, 3 patients' lives are being saved because of this. Very simple again. This is something that is. Similarly, this is very interesting. A patient coming, we do about 2,000 surgeries a month. Every patient coming in for surgery has to get a pre-anesthetic checkup. And you see in a pre-anesthetic checkup, he has to go to 17 points. 17 points, X-ray, ECG, cardiac checkup, anesthetic checkup, all these things before he reaches the surgeon who says, okay. 20% of people are exhausted. They say, we don't want to go further, so much of going around and all that. So what is the solution? Again, AI helped us. We made what is called the spaghetti graph of how individual patients go in 1 month. What is the solution? Then solution was to have a separate tower where all these facilities are there. I mean, this looks very easy again. It doesn't require AI to think of it, but you have to use AI because now you put a separate tower, you put all this instrumentation. You have ECG machines, echo machines, and so on. You have doctors separately manning this. So if you put in so much expenditure, we'll have to calculate whether it will be beneficial. The calculations is done by AI based upon 2 things. One is the amount of expenditure we put in and what would be a positive footfall. How many absentees would now become positive? And it calculated that it will be 99.9%. And once we did this, it was 99.91%. Everybody came back for surgery. They come in the morning, spend about 1-2 hours in the morning, get everything done in one place, have a nice cup of coffee and cookie, and then they tell their relatives, I'm going back there again to get surgery done. So they all came back. So this is again how it has been useful. So this is the lounge we set up. They come here, have their, check up, everything done in 1 hour and use. So again, very useful. The third thing is the patient endoscopy patient tracking system. Our hospital has the largest endoscopy center in the world. We have about 40 endoscopy rooms. We do 700 to 800 procedures a day. Again, largest. The next biggest is Mayo Clinic, which does about 300 procedures. Next biggest in the world. Ours is 800 procedures every day. When the patient comes into the endoscopy area, he's sort of lost. They get inside. I sometimes don't know where the relatives ask me, where's my father is gone in for, so I don't know where he is, which room he is. So sister doesn't know, nobody knows. They're lost only sometime in the evening we discover where they are. So these type of things are occurring because such a large unit, nobody has the unit like so nobody has written. So what we did is, how do we solve this problem? So we use this tracker system where the patients are given RF bands. They're tracking everywhere, wherever they go in this 1 lakh area, 1 lakh square feet, a large area, and then continuously they're being tracked. So, and a QR code is made, so the relative is given that, and relative knows he's going to endoscopy room, is getting endoscopic surgery done, is coming out in next 15 minutes and so on. Plus, we have this chart which is telling me on my iPhone or anywhere which is projected any part of the hospital. It tells me that this particular patient was 5 minutes in the reception, 43 minutes in the pre-procedure 19. So they're starting to accumulate there. I send a group of doctors, immediately clear this, because the TAT time, key performance indicator, TAT time should be less than 2 hours. We have now reached 1.3 hours, which is much better than what Mayo does also, with half the number of endoscopies. That's because of this tracking system and how we created this. So again, showing how currently AI can be used in endoscopic operations. And again, I showed you about the microbiome. In our lab now, using machine learning, using AI, we can actually differentiate between various complex diseases which can't be done by natural clinical method. But this is very interesting. This is something I want you to again see very quick. This is made a product of what we did in terms of AIG and ISB collaboration, where we kept in different groups and they're asked to make algorithms. And to give you a little background on this, 30% of Indians have fatty liver. Significant percentage of them go into cirrhosis liver and hepatocellular carcinoma. Highest number of hepatocellular carcinomas in our country is, in the world is in our country. So it's very important to diagnose these people. How do you diagnose them? We diagnose them by a technique called FibroScan when they come to hospital. FibroScan machine costs about 2 crore rupees. The test costs about 10,000 rupees. So it's very difficult to do it for everybody, apply it and all. So a group of our very young hepatologists took this up along with our AI team and did a prediction model. And you can see this, what they did was they took 4 parameters, blood parameters costing about 150 rupees, 4 parameters, and 2 additional small parameters. Using that, they do algorithms. I don't understand how, but anyway, what they did was they actually saw if the algorithm can predict a FibroScan picture just using only these parameters. And you can see here, in this particular patient using this algorithm, they found that FibroScan showed fat of 277, fibrosis of 62. Now let's see how their algorithm performs. Just using 150 rupees for blood test, this is their algorithm, and they showed 270 and they showed 6.8, almost identical. So now you are converting a 2 crore machine, 10,000 rupees into 150 rupees, can be applied even in the villages. In fact, we just was actually negotiating the government of India to start a whole country study of using a FibroScan to see what is the incidence of this, because the largest public health problem in our country is this. So, but we came to a stop because the government said we can't get you 2 crore machines to go to 100 places all over the country, it's too much. But now we have a solution. We can do this now without this all over the country. The other very interesting thing is this, that every person here has a genomic system which reacts differently to different drugs. doctors are taught wrong things. And one of the wrong things we are taught in medicine is textbook saying you give one tablet twice a day, one tablet once a day. Hypertension, one tablet once a day. Diabetes, one tablet once a day. That's what we are normally taught, and we do this. We think it's right. But we found actually using the genomic pathways and algorithms that when we took patients in our hospital, 1,500 patients, a paper that's going to New England Journal now, when we did this, we found that 40% of the people, the prescription had to be changed. No, not only because they had different enzyme pathways, which is different in different people, but also the drug-drug interactions. It's a very complex phenomena which only AI can resolve. So we found that 40% had to change the prescriptions. So one patient for acidity required one tablet a day, other patient required twice a day, some other patient required once in 2 days. So now we recommend that any patient coming into the hospital requiring more than 4 tablets a day, four tablets a day for different diseases should get a pharmacogenomics, which is now very cheap. It's about 3,000 rupees they can do this algorithm. And then we prescribe them, and this for rest of the life, it's there for the patient. He can go to any hospital, show this, and get his prescription. So this is something which we have also made. The other thing that AI is going to make a difference is predicting and preventing epidemic outbreaks. Unfortunately, when COVID came, we didn't have this facility. That's how COVID spread. Recently, nobody knows this. In about 6 months back in China, there was another small outbreak of another rare virus. And they used AI to contain this. It never went out. Nobody ever knew. If we had an AI algorithm during the COVID time, I'm sure we wouldn't have suffered all this and all. This is another remarkable area where AI is going to make. And now we are prepared. We can use this immediately. If a patient with unusual type of pneumonia comes, we can put that whole area under tracking. All the hospitals report this type of pneumonia. Surrounding areas report. We know how many flights are going out in that area. We know what happens to these people who raise some other area. All this can be tracked, AI made, and then we can actually predict. So I think this is going to be another area. The last area where, again, we have made a tremendous difference, and let me explain a little background to this. When I see a patient, normally I would talk to him, make a diagnosis. But last 5-6 years has changed because of electronic medical records. Every hospital now wants electronic medical records. When I talk to the patient, I'm not talking to him, I'm typing all the time on the screen. So out of the 20 minutes, 18 minutes I'm doing this, 2 minutes I'm giving an eye contact. But medicine is different. Medicine is all eye contact, how you interact with the patient and so on. Patient not bothered what you're typing in the computer. Unfortunately, EMR made us do this. So can we overcome this? And this again, I think Kinjal and his group had made something very brilliant. They call this a prescription recorder intelligence summary. I'll just put this on to show you what we do. So you can see this is a patient who's come to me. And
सर पेट में बहुत दर्द हो रहा है सर एंड इधर बहुत क्या पेन आ रहा है सर
कितने दिन से हो रहा है
सर 2-3 मंथ से हो रहा है सर
2-3 मंथ
यस सर
और जो जलन हो रहा है ज्यादा छाती में
यस सर ज्यादा हो रहा है सर
नाजिया या वॉमिटिंग है
यस सर
भूख कैसा अच्छा है
यस सर
भूख ठीक है
यस सर
और मोशंस का कोई प्रॉब्लम है क्या
मोशंस नॉर्मल सर
स्टूल्स नॉर्मल है
यस सर
कुछ प्रॉब्लम्स है पास्ट में कुछ डायबिटीज या
नो
बीपी का तो नहीं है
नो
हाइपरटेंशन
नो सर
ये प्रॉब्लम जो है ना
यस
वो आपको कुछ पेरेंट्स को भी है
है सर माय पेरेंट्स को भी है सर
पेरेंट्स को भी अल्सर था
Yes,
फादर को अल्सर
अल्सर यस सर अल्सर
So Rajesh, your diagnosis looks like peptic ulcer. So we'll have to do endoscopy and ultrasound. For that, I'll start your medication, pantoprazole 40 mg daily. Once we do endoscopy, we'll give the pilot.
so I talk to him all the time. At the end of the conversation, I just make a click on the computer and see what happens. What all I talk to him comes not only very clear, but in a segmented form, past history, present history, algorithm, lab orders, everything is there. I've never looked into the computer at all. And this has just taken me a few seconds. And most important, again, I was thrilled with this was that when you're talking to the patient, you talk some gossip, have you seen Pushpa movie and all, that doesn't come in. It is intelligent enough to filter out all those things, case only medical. So this is something which is, so this we have validated in almost 40,000 patients now records. We want to do it 100,000. And I think this is going to transform the way how patients in India are seen. Hopefully, I think if we can do this in a large scale, give it to all the hospitals all over the country, you know what happens? Electronic medical records are going to be uniform. Even United States has not been able to do this. We can make electronic medical records talk to each other from different hospitals, which becomes very important so that information is transferred this way. And I think this is a major achievement we would be doing if we can carry it through further. And this is another interesting thing. This is a patient who came to me with pancreatic cancer. There's a cancer there. Unfortunately, he already had a cancer which couldn't be operated, and he'll die probably in next few months, 3 months, 6 months. This patient has been coming to us for last 3 months, and last 3 years. 3 years back, a CT scan is also available. It reported normal. When we showed this report to our radiologist, the very, very good radiologist, said the 3 years report is normal. We sent this report to one of our top radiologists in Mayo Clinic, the best guy in the world. He said 3 years back, it's a report is normal. But when we gave it to AI said the 3 years back report that it's likely next few years the patient is likely to develop pancreatic cancer. So AI saw something which nobody else saw. AI is reading this, and now we want to outsource most of our radiology to AI because it's cheaper, and I believe it's much more consistently better. This is another major area. And this is another interesting concept that this was a paper in Nature, very prestigious paper. 25 top dermatologists in New York City were shown a patient's some skin lesion. And this skin lesion, they diagnosed skin cancer, melanoma, tuberculosis, and so on. When they show it to artificial intelligence, it said this is amyloidosis of the skin, very rare condition. Not many people have seen amyloidosis of the skin. And he said, so people thought maybe it's hallucinating. I believe AI computers can hallucinate. I didn't know that till that time. It was hallucinating. And when a biopsy was done, sent to the pathologist, pathologist said it's amyloidosis of the skin. Exactly what AI has said. Every top dermatologist has missed it. So there are many lesions like this in dermatology, for example, which are going to be taken over by computer vision, which is going to more accurately diagnose. Certain branches of medicine, like radiology, dermatology, are now being slowly overtaken where AI is going to make a predominant part. And this is again very interesting. I didn't realize that something like this could happen. This was a study which was done in Mayo Clinic, where Mayo Clinic does an outreach study. All the counties around it, they go and do ECGs in patients to see any cardiac disease or anything. But when they're doing this, they found to the surprise that ECG was not only diagnosing cardiac disease, but the ECG was also telling the doctors, this patient has liver disease, this patient has cirrhosis, this patient has liver cancer. They were shocked. They didn't know, because they didn't build in that program. They call this unexplainable AI. I don't know what it's called unexplainable. So you can actually get a cite something else even without building in the program. And it was so accurate, it was much better than the CTs and all that. It's a major paper they just published. Part of it is also in New England Journal, where they showed that you can do that. And similarly now, we can do this eye. In looking at the eye and using AI now, you can not only diagnose what is wrong in the eye. We used to look at diabetes, hypertension, looking at it. But now you can diagnose liver disease, you can do an NFLD, you can tell a patient has gallstones or not just looking at the eye. No need of looking scan. So there's something again it's picking up there which no other, we don't know how it's doing it. So these are all, I think, things that are very exciting. So coming to the last part, again, many doctors ask me, the younger doctors, you're pushing all this because I'm a great pusher of AI now. Our team is being pushed like anything to do all sorts of things. Is it going to replace them? That's a worry. I think, again, coming back to medicine, I think it's still a very conventional thing. You see patient, touch patient, make a diagnosis. AI has its role, as I showed you, mainly in the operational aspect, sometimes in diagnosis, but will not be able to replace doctors. But what is going to happen is that AI is going to have a role definitely. And one of the roles I thought AI never had was, as a doctor, we're supposed to have empathy. See the patient. Empathy is not sympathy. Empathy for the youngsters is getting into the skin of the patient, how he feels, how the relatives feel, and act according to that. That is empathy. I thought it's impossible for a computer to have empathy because it's very mechanical. But this is a study published in JAMA, Internal Medicine 2023. What it did was very simple. All the patients are discharged after surgery, after some procedure from the hospital, were asked to call back the hospital and then say, I have some symptoms, diarrhea is there, pain is there and all. And they were randomized. These calls were received, one by a group of doctors, second by this computer with AI. And then the patients were rating who is better in terms of empathy, how they were empathetic and all. And here they found that computer with AI was more empathetic than doctors. So the last bastion the doctors thought were better is gone. So computers are more, because you train it to be better in that sense, you know. So that was the thing. So for the clinic, so what I tell our doctors that AI is not going to replace doctors, but a doctor who knows AI is going to replace a doctor who doesn't know AI. This is the next near future that's going to occur. Of course, so you can see for the AI for clinician, it helps us rapid diagnosis, accurate interpretation. I think the maximum benefit for healthcare, and this is again not emphasized even in the lay press and so on, is for operational efficiency. AI is going to make a dramatic betterment in our operational efficiency in the hospitals. And of course, personal health is becoming important, and I'll just come to what's going to happen in near future. We are now getting these types of new AI beds. We just got one in a hospital, but more sophisticated ones are coming, where your patient lies down on the bed. Normally, intelligent bed will measure the temperature, will measure the weight, the height of the patient, and BMI calculation. But this particular bed can do all that. Also measure the blood sugar, sodium, potassium, calcium, heart rate, blood pressure, heart rhythm, everything. Everything the doctor does. So you just put the patient in an ICU bed like this, and we connect it to the treatment. When you connect it to the IV fluids and all that, the bed is measuring constantly, dynamically, what's happening to the pulse rate, blood pressure. So if the blood pressure drops a little, the bed automatically talks to the IV drip that's coming and increases the drip, increases the medicine. So that it's an interoperability between these two machines. I think that's a new thing in AI, which is going to control. You don't have to be anywhere near, everything is done. There is, of course, what happens is these beds are expensive. But what has been shown is that normally in ICU, if you use, for every bed we have 2 nurses. But if you have a bed like this, for 5 beds you can have 1 nurse. So ultimately you save on the manpower. This is going to happen. But there's also a danger. You can hack into this bed. In fact, there was a recent example in Germany, in a German hospital, one of the Russian opposition leaders was admitted, and they could hack into this bed and completely change the dose of medicines. So blood pressure dropped, and so this danger is there. I think one has to be careful about that. This can occur. Similarly, I think all of you must have heard about the Neuralink, which looks very very sophisticated, with Elon Musk, of course, who's not particularly popular now, but anyway. So he's created these small chips which have 1,000 small threads which are put into different parts of the brain. So if you're paralyzed, you can't move your hand, with this chip put in now, it will actually tell you, the brain will tell, the thinking part of the brain will tell the motor part of the brain, raise your hand. So you can raise, they've shown that putting in, people can drink, they can write, they're getting into small this. I think this is going to be a major dramatic, I mean, if you think of people who are paralyzed, or motor neuron disease, or Parkinson's, we're having all sorts of problems, brain is still active. This will again dramatically change what's happening, and I think it's being pushed by the government of United States for better. But the most interesting aspect is mobile. All of you are wearing mobile devices, smartphones, rings, all those things. But our personal health can be better monitored, and my own, with many of these mobile devices. One of the interesting things is smart toilets. I was asked to give a talk in Hong Kong in January on AI in future, microbiomes and so on. So I made this slide where you sit on a toilet here, and you get a lot of, your stool is analyzed by AI, microbiome completely. So your microbiome is analyzed, and then it says, okay, eat more carrots, work to sleep, all the type of information. So you're not wasting your time in your toilet, you know, so sometimes useful time. So I made this going to give a talk, and I found as I was entering into the conference hall, this, like a conference, instead of a tea stall there, actually this was there, a toilet, an intelligent toilet. They actually made a small chip. So if you go into the toilet, then immediately it'll tell you that today your brain power is not so good, kindly be careful when you're talking, things like that. So I think this is already come, they're commercializing this toilet, so this is going. But look at other wearable devices we usually use. So there are many now doing this type of, Rakesh knows this, Rakesh probably is also in the scheme, where you have all this. So for example, my data can be on a phone, I can have a watch, smartphone watch, I can have many of the patches. With these patches now you can continuously measure your serum cortisol level, your interleukin levels, your IL-6, IL-10 levels, and the best way to measure the health in a person is something called VO2M. This is the oxygen maximum that we can measure. It's the best health measure. All this can be done with this, and weekly I can get my microbiome done. All this goes into the cloud and goes into a server in AIG, which already has my previous genomic data. Now, this can be done right now today. It doesn't require more, it's not very expensive because all these smart devices are. So just imagine every minute we can monitor our personal health using a combination of this digital technology and AI. Telling us, for example, I may be getting messages now saying that your heart rhythm is increasing, your time is up, kindly finish your talk quickly. Otherwise, so that type of thing, everything can be coming in very quickly. There are, of course, many challenges. I don't want to go too much into this because challenges, one is the data. The data has to be pure. If the data is not pure, what you feed in, what you get out is going to be totally wrong. And this is what our doctors, hospital group is not recognizing. Data has to be extremely pure, and this is something that we keep. The other problem of ethics, as I told you about what happened, that you can interfere with this machine, so this is a problem. And the other problem is regulatory. Unfortunately, none of our government people, or even I think internationally also it's a problem. They don't know how to regulate AI now. Fortunate for us who are working in this area because they can do a lot of things without regulation, but ultimately regulation has to come somewhere. How to do, what type of regulation, I think these are questions that the government will have to answer. But the most important thing is going to be cyber security. So much of data we have. There's an example recently in All India Institute of Medical Sciences where I think about 40 million data breaches occurred. And there's something very interesting I learned from Kinjal, that there's something called dark web. In the dark web, if you sell your credit card, you get $10. But if you sell a medical data, you get $250. So you can imagine people trying to steal the data, and then sometimes you have data of top national leaders and so on. So cyber security is going to become, this is going to add cost to our AI. I recently read that Microsoft has bought some huge cyber security company because cyber security is going to be such an important area of AI in health. We have to protect all the data. So I think data is very important. If you go to the US dollar, even in the dollar has got this in God we trust. I don't know if they have one anymore, but anyway, all has in God we trust. But I think for all the AI scientists, it's data we trust more than the God, I think, after the God. So this is very important for us. Again, I'm extremely fortunate that with IIIT, we signed this MOU where we're working together. We are thankful that some of your scientists are there with us, guiding us, helping us. We're working together. I'm sure together we can bring about a new revolution in AI, because this subject is very new. If you go to even the top institutions in health in India, they're not very aware. They're not knowing what is happening. And I think we can partner this into making it into a very big thing. Because I have a dream. I have a dream that AI will be used more often in health in our country. AI will be effectively used, and more important, AI will make medicine equitable. That because of AI, whether you're rich or poor, whether you're in the village or you're in the city, whatever community or creed you belong to, you will get equal type of medical care. Thank you very much for it. Questions are okay, but not tough ones, huh? Not on not on engineering questions. For medical, you can ask. Yeah, you can shout. I can hear you.
My understanding is that medical education is not that you look into the eye and diagnose there is a cardiovascular condition. That is not how the traditional medical education is taught. Do you think with all the new discoveries we are making, you're linking ECG to fatty liver, and so how all of this is going to make an impact on how medicine is taught? And obviously AI has a lot of impact in care.
So I think that's a great question. What impact? I think one of the things that I worry about is first that all these things can de-skill medical people, decrease their skills. For example, it took me 40 years to learn endoscopy to come to a conclusion that this is cancer, this is not cancer. And now one of my residents training after 1 year can put in a scope, an intelligent scope will tell him this is cancer, this is not cancer. So he's going to be totally de-skilled. He doesn't have to go through the learning process. And the possibility is there that if AI makes a mistake, it will make a terrible mistake. And then who is responsible for that? In fact, recently there was a court case in US where the polyp detection was missed by AI. And the patient sued the hospital. Hospital said, not our fault, you go and sue AI. Now how can you sue AI? He couldn't sue AI, so he went to the consumer court. The consumer court said that person who is using AI is responsible, not AI itself. But these things are going to be problematic. Who takes the responsibility? Teaching medicine is not going to change, it's going to, I think medicine to me is still the conventional method. You see patients, diagnose and so on. But I think all these are going to be additional aids to us. Unfortunately, like you said, we started over-depending on this. I don't want to diagnose a fatty liver looking at the eye of the patient or ECG of the patient. These are examples of what AI is doing, but I don't want to use that. This can be used for mass. If suppose I'm doing 1,000 ECGs in some village somewhere, instead of my examining, instead of doing an ultrasound, if I get an idea that maybe 10 of these people are having liver disease, I can concentrate and look at them. That's how it's going to. But conventional medicine will not change and should not change because of AI. But there is a danger that we de-skill our younger doctors because of overuse of this. Yes. Yeah, please. Yeah, you can, I'll translate it.
So, yeah.
Ladies first, I think.
Oh,
Yeah.
thank you.
Yeah.
Especially in country like multilingual country like India, we speak multiple languages, and mostly the interaction happens in particular language, right?
Yeah.
The example that
Yeah.
you have shown in Hindi. Do you think that in future, like, we are also interested to work towards that one? Do you think that the more colloquial languages, the more
Yes, sir.
dialectal
So yeah,
variations
that's
that
a
they
very
are
good
bringing?
question. In fact, Kinjal can also answer. But so this is done in 4 areas. Currently, we can patients. See, that's why I spoke half Hindi, half Telugu, and half English in that. So you can do Hindi, English, Telugu, and Bengali because you get a lot of Bengali patients. We use Bengali, but you can do it in about 10 languages. You can do it in Tamil, you can Kannada, everything you can do. There's no problem. Not a very difficult thing to do. So I think. What we do is when you develop this system, sometimes you have to use only colloquial languages only. You don't, for example, in Tamil Nadu, you should not put Hindi into the thing. You get into trouble also. So you do only in Tamil there. That's the thing. Yeah, please.
So, how do you think AI is transforming mental health care? And for technologists here, what might be the 1 or 2 use cases that we should focus on?
Yeah, so this is another very important. Because I didn't have the time, I didn't go into. But cognitive behavioral therapy are becoming very, very common now. In fact, there's a lot of evidence now that conditions like dementia, Parkinsonism, and so on, you can actually predict long before they come using AI. There are now AI tools which can predict that in next 5 years, this guy is going to be dementic. I don't want to use that because I'm worried. So you can use a tool now that is one for early diagnosed dementia. Once you diagnose it before the onset of dementia, there are now many cognitive behavioral therapies available which can actually delay the onset of dementia. You may not be able to completely treat it. So I think AI is going to make a tremendous role there in that area and a lot of research going into this. Again, because of time, I couldn't get into this. But AI for dementias, for Parkinsonism and so on is going to be a very important tool for predictive diagnosis and individual treatment of each patient. Yeah, yeah, please. That's another very important question. Again, I didn't have time, but what happens is traditionally when a drug is discovered, normally it takes about 20 years for drug discovery. We make a hypothesis that this drug is probably acting on this enzyme here, and then work it out in actual life. If we try 100 drugs, maybe 1 or maybe 1,000 drugs, maybe 1 is useful. It takes years and years and 20 years, and vaccine developments we're taking 30, 40 years. What AI has done is the first part is completely made it so fast now, it's in weeks. You can actually now, for example, if there's a particular targeted therapy, one patient has leukemia, we know that in blood cancer, the blood cancer cells have an abnormality in one particular enzyme. For example, tyrosine kinase, it's called enzyme abnormal, or subunit of that enzyme. So immediately we can create an AI model of this enzyme, and we can now, using computational science, make several molecules to see which acts on that. And then using again on a computer you can actually make a model of this particular drug is the most effective for that. And within a month's time, I can come up, which it took me 10 years to come, but in a month's time I can come up with a drug for this. The next phase of development is to test these drugs on animals. Again, using AI predictions, we can use this in models to very quickly come to a conclusion that this particular drug is effective. And the final stage is stage 4, where it goes into human research. That is where AI is not acting now, still not there. So in that sense, the last phase is 3 to 4 years. So you can get down drug discovery from 20 years to 3 to 4 years. And the most important thing about it is it doesn't require too much infrastructures. I've seen recently, I was in a small city in Maharashtra where for some other reason, and I found that there were 3 or 4 groups of scientists, AI computer scientists, small labs working on drug discovery, showing me different molecules for leukemia, for this cancer, for TB, making it on the computer and sending it off to like big pharma companies are taking it up and trying it out in the next phase. So I think drug discovery is going to become much more widespread, much more faster, and is going to occur in small places. It doesn't require to have a Pfizer lab in New York to make a drug discovery. Now you can do it anywhere. So this is the most important change that's coming.
Doctor, I think they informed me this would be the last question.
Okay.
How is the reception on the other side of the table? Like, yes, doctors are using AI and getting good inputs on that, but when you tell a patient that, okay, I diagnose 90% of your thing, the other 10% is AI what it's done. How does the patients feel? Are they receptive or skeptic?
So this is also a problem. This is the other way around. In fact, it's actually a little tragedy because patients have a hyper view of AI. They think that AI is something very superior. So unfortunately, doctors, or even not doctors, especially medical management or hospitals are now misusing this. They'll say AI-directed cancer therapy, AI-directed PET scan, AI-directed. All these are advertisements attracting patients, unfortunately, in the wrong way. So I think this is something very important. In fact, we have to educate patients that AI doesn't mean something superior. AI has a specific use in some areas. But just because you have an artificial intelligence CT scan, it doesn't mean you're better in that. And patients are actually liking it too much. That shouldn't happen at all.
Thank you so much, sir. That was a wonderful speech. Thank you, Dr. Reddy, for this inspiring address. I would like to invite Professor P.J. Narayan to give a token of appreciation. We are delighted to announce a significant milestone, the inauguration of the Center of Digital Health at IIIT Hyderabad. This marks an exciting step forward in advancing research, innovation, and collaboration in the field of digital health. I would like to invite Professor P.J. Narayan, Director, IIIT Hyderabad. Under his leadership, IIIT Hyderabad has continued to push the boundaries of research and innovation. So, we would request you to share a few words with us.
Thank you very much for this, and that was a fantastic talk, giving all sides of AI and especially its potential in transforming healthcare, all aspects of it. The good thing is we have been working with AIG for the last several months, talking to them, and several years ago we also thought, we at IIIT being a strong AI center or a technology center, we should be doing things which directly connect with the society in a very, very direct way. So focus on applied and translation research has been there for the last 5-6 years. We've been pushing internally, and the hub that was created here also has a mobile phone-based diagnosis of oral cancer, just for screening, not really diagnosis, screening for that can be taken to the villages and that suspect case, patients can be identified, etc. So thank you, Dr. Nageshwar Reddy, for giving such a good overview of what AI can do. And the way he ended was also very nice, that today there is too much dependence on AI so far. And when AI is doing more and more things, there is one story that I say often, which I would like to repeat here, because there are a lot of doctors present here as well as technologists. So I would say that he made his talk, why doctors fear AI. I will say why engineers don't trust AI, okay? So here's a story from, it's a real story from, narrated by Professor Michael Jordan of University of California, Berkeley. He's one of the foremost experts in machine learning and AI today. So he, in a few years ago, when one of these forums, he gave this, he talked about AI and its perils. And he said in about early 90s, his wife was pregnant, and as a routine matter, they took the a scan, ultrasound scan, and then the radiologist showed the ultrasound scan and said, oh, here are these white markers. These are markers for Down syndrome. And so what is the next step? Based on that, you do an amniocentesis and take the amniotic fluid and look at and see if there is actually Down syndrome is there. So Michael Jordan, being an engineer, didn't trust the tool that created this thing. So he went on his research and found, he did a lot of research. He's an image processing guy also. So he looked at how this was developed. And he found out that the particular camera used in that ultrasound and the algorithm to predict this thing was 25 years old, study in Britain. And since then, the camera technology has improved a lot, and the latest machine that they use has much bigger cameras, higher resolution, and as a result, higher sensitivity, and hence it picks up more noise. So he concluded this is actually sensor noise. This is appearing as white patch rather than actual thing, and he told the went and told the radiologist that I don't want to do this amniocentesis, and this is the case. So the doctor remarked saying, that's why we had more cases reported when the new machines arrived. And then he goes on to say that amnio has 1 in 100 chance of, of fatality. The fetus has a 1 in 100 or 1 in 200 chance of the fatality. And he's just saying that, at that day, that time, probably 1 million ultrasounds were done all over the world. And if they all use this method, and a good number of them were misdiagnosed as the Down syndrome marker, and they all went amniocentesis, maybe several hundred babies would have died unnecessarily. So this is the cautionary tale about what goes. I mean, AI is great, the algorithms are great, but anything is as good as only as the data fed to it. So this is what also we need to keep in mind. In any case, I mean, we are very excited to have this Center for Digital Technologies in Healthcare established at IIIT Hyderabad. We thank Mr. Srini Raju, who has been pushing us, saying, I will say things that he says which none of you will like here. He says, why are you all focusing on this paper writing and publishing? Let's do things that actually affect. I want to count how many people have been touched, how many patients, or how many people on the society has been benefited from your technology. So you should be working on that thing. I will support you for such thing. So with his support, we are launching this Center for Digital Technologies in Healthcare. The focus is on research translation. There is translational research and research translation. I'm trying to find out these fine lines between these. Applied research and translated research still belong to research. Output may be papers, output may be studies. They are all very good. You need that. You need academics, you need practitioners there. But translational research is the next step where maybe the work is mostly done or known, some tuning may be required, but the task left is to take it to the field. It's the engineering, it's development, it is user study, it is dealing with the regulatory bodies, it is dealing with government, it is dealing with patients. All the nuts and bolts aspect of how this becomes a solution, how this becomes a package that goes into that somebody can use, doctors can use, or other public health professionals can use. So this is research translation. So this center should be doing 90% research translation, maybe some 10% to support this thing. And we also have evolved a model. You'll hear from a couple of people who are leading it on what activities we are starting with. We are working with AIG has been a big partner. We identified 3-4 projects from AIG, and We had a meeting about a few months ago in which Dr. Nageshwar Reddy said he'll come for half an hour, and he ended up sitting there for 2 hours saying all kinds of stories, and that enlightened us. So we are working with, we're looking at other hospitals and getting other case studies also, so that the intellectual potential of AI that is available here is actually translated into solutions through teams that are focusing on development and solution building, and helped by probably by professors and other researchers as in some advisory capacity. This is the model we are following. This is the model we think is necessary to make it really translate to the field. And we need all kinds of technical help, which probably we can get, but all kinds of domain help and all kinds of policy and other help, and that's why we are counting on. I want to acknowledge Sri R. Chandrasekhar here. I had just had a half an hour, 1 hour conversation with him over dinner a few weeks ago, and he was talking about all the governmental policy and perceptual challenges involved in here. You may have the best solution, and that may not work, may not be practical. A simpler solution with a different positioning may actually have bigger impact. So these are also things that we keep in mind, because ultimately this center, we don't want to just develop things that are published and stay in the shelf, but that are used in the field. So this is my rather longish introduction to the CDiTH. I'm sure there are people here who are going to talk more, give more details, and then we will unveil we'll formally inaugurate it. Thank you.
Thank you, sir, for those inspiring words and unwavering support. Next, I am pleased to invite Professor Bapi Raju, a distinguished researcher whose expertise in cognitive science and artificial intelligence has greatly contributed to our institute's research landscape. So, we would love to hear your thoughts.
Good evening. I have the opportunity here to share the various healthcare activities that are happening across variety of centers in IIIT and where the new center fits. This is a brief overview of So this is my one slide capture of what's happening, has been happening at IIIT across various centers. In the middle, what you see in black are names of various centers. Just to give an idea, CCNSB stands for Computational Natural Sciences and Bioinformatics. CVIT stands for Center for Visual Information Technology. RRC Robotics Research Center. So these are different names. And what I have here on the outside are different themes, domains where healthcare solutions have been developed over the years. So what you see in smaller font are actually projects that faculty members, teams of faculty members across centers have done over the last 10 or 12 years. So core technology areas like image processing, medical imaging and analysis, speech and language technologies, and AI and ML in applications of that in drug discovery. Apart from that, different domains, public health, screening, rehabilitation, assistive technology is not just the software development, but hardware solutions for screening, diagnosis have been done across variety of themes, including mental health and cognition. So in the interest of time, I will not go into each of those, but you see the spectrum, both, there is a bench strength and interest is what I want you to take away. And there are faculty here, I see several faces, you can also talk to them about individual projects. Now, as Professor Pijan shared, there's 25 technology innovation hubs set up across India, and IIIT Hyderabad has iHub Data, a technology innovation hub set up to curate data sets. We have the left-hand side, what you see is indiadata.org, Org, it's a data platform that provides compute and storage for data sets, and currently 1.6 petabyte storage, 96 GPU cluster available for storing validated and clean data sets, and also developing solutions on top of them. And currently there are 16 data sets across different varieties: cancer related, neuromental health, public health, and one of the the drug discovery data sets are present on this website for initiating development of AI solutions. And so many of these data sets have been curated with the help from government funds, so it's our duty that these are accessible to others to bring value addition to these. That's the idea. And this platform can also run challenges, data challenges, and so on. So this is a snapshot of couple of them. One of them is the whole slide image data set that Dr. Vinod and team has developed. And the bottom is a drug discovery data set of different protein ligand interaction data set of 5,000, 20,000, and the current push is to develop a 100,000 protein ligand interaction database. Right? So, and we understand, as Dr. Nageshwar Reddy pointed out, awareness training is important. We have undertaken a course jointly with National Academy of Medical Sciences. It's a 12-week online orientation course on AI for medical professionals. About 140 medical professionals participated. The first cohort, September to December. Most of these were mid-level senior clinical practitioners that underwent this course. They were experts from NAMS, experts from IIIT that participated in this course along with hands-on training. The second cohort is starting sometime in April. And the overall impact over the last 3 years, specifically with this TIH that has been initiated with DST, there's 18 partnerships, 16 projects, and over 75 publications that came out of this TIH. And these are some snapshots of translational research. The left one is the oral cancer app that Professor Pijan alluded to earlier, and this is a wearable bioelectrical impedance belt that allows monitoring of water, oral glucose load, that has been developed with National Institute of Nutrition as a validation partner. And the last one is Professor Jayanti and team has put together a product called AnaView, which is helpful for human neuroanatomy education. This is the views are developed with a patient, one normal healthy controls DTI and T1 images. And this is being deployed at Usmania Bhaskar Medical College and so on. And so what is the path ahead? This is my last slide. Summarizing what Sir Pijan said, that we have been doing basic research, applied research to some extent, and the recent push with product labs and I have data, translational research. And we think the natural path of the evolution is the research translation that CDiTH will nucleate deployable solutions with known technologies and develop solutions to be deployed at scale. Now I'll ask Mr. Raja to quickly go through the execution plan of this proposed center CDiTH.
Thank you so much, sir, for those inspiring words. Lastly, we have the pleasure of inviting Mr. Raja Polati, Head of the Center of Digital Health at IIIT Hyderabad. His vision and expertise are at the core of this initiative, and we look forward to hearing his perspective on the future of digital health. So the stage is all yours.
Good evening, everyone. Thanks, Bapi, for setting the stage. We are short on time, so I'll keep it short. So essentially, when we looked at all the work that's happening inside IIIT, the work that Bapi has referred to, we identified that, hey, we are doing a lot of healthcare work. And then we thought that it's always nice to have a top-down view of areas that we can focus on so that we can reach out and seek projects where we can really make a difference. With that understanding, applying, trying to identify areas where we have an expertise, as well as where we have potential access, we have identified a few areas where we thought that in the oncoming time, we can probably develop our expertise. And these are gastroenterology, predominantly with AIG. Cancer, we are working with several institutions with Grace Cancer Foundation and NGO. We have undertaken one project. Cardiology, neurology, maternal and child health. Again, we are working with AIG in this particular space too, thanks to their Janani Mitra app. We want to produce some solutions. And large healthcare systems, we are hopeful that with Srini Raju being there, we would be able to reach to both Arogyasri as well as ADHM and then undertake some projects where we believe we can make a difference. Going forward, very briefly, I mean, CDiTH is going to be a separate center with its own set of engineers. But having said that, I think we realize the way CDiTH is different is it's always going to work closely with either a hospital or an NGO and with the faculty of the institute in various means. So the starting point for CDiTH project is always going to be a problem which would be identified in close collaboration with either a hospital or an NGO. So that's probably one way in which we can imagine how CDiTH is going to undertake projects be different than how probably we do it in most of the other centers. And the job of these projects is going to end only when we manage to deploy them in production. So whatever we need to do to ensure scalability, responsiveness, security, some of the topics which we talked about during this course, all of them are going to be focused. And we realize that to really make a difference and leverage the expertise of IIIT, we got to engage the faculty very well. So there's a lot of focus, a lot of discussion that has happened on how to engage faculty in a win-win fashion so that they have something to look forward from this engagement, from these projects, and the center as well as the hospital can gain from those expertises. So we discussed a few models, but at the very short, as we also have discussed, they are going to be engaged in an advisory role. And we would be engaging across all stages. We have identified a framework. I'll not go through that, but across each and every stage in providing the right inputs, making sure that we are considering all approaches, picking the right approach, analyzing the results. We want to keep the faculty engaged, and for every project, we want to have at least one faculty member engaged so that we kind of accomplish the vision and the promise of this center. And lastly, just to give you a glimpse of the nature of projects that we are undertaking at present, there are 4 projects in various stages of execution. The first 3 are with AIG. The first one is a food scanner and the nutrition calculator, which is, there are a few of this nature, but we want to build a model which is more appropriate for Indian home cuisine, and that can be used either on the field by ASHA workers or in hospital settings, or there are a number of other use cases which we have learned where it can be put to use. So that's one. Second is a non-invasive anemia detection mechanism. I know that we did this exercise in the past, but there was a paucity of appropriate quantity and quality of data where we could not achieve the desired success. Now, by partnering with AIG and with their app, the Janani Mitra app, which is going to be used on the field, we are very hopeful that we would get access to the right quality of the data in hospital setting, in a controlled setting, as well as on the field to produce a model which is going to be of a high quality. And the third project again is in the area of, sorry, not again, but it is in the area of the gastroenterology with AIG, where we want to use AI for pre-screening of achalasia, where we hope that this would enable, it will reduce the dependency on experts in certain settings, and we also are hoping that whatever we learn out of this engagement, there could be several adjacent areas where we can apply or identify projects where we can apply AI and our expertise of IIIT. And last but not the least, that we are undertaking with Grace Cancer Foundation. They have a large amount of radiology and cytology reports. Reports are there for a huge amount of population, and they need some assistance in automatic feature extraction of this from these reports, from the textual reports, and perform some kind of a risk stratification so that they can focus on the right patients to make sure that they give them health in the right time. This was one of the challenges that was identified in the earlier keynote. So that's one of the last projects. We are quite excited about these projects. They are in various stages of development. And I think for us to achieve the goal that was laid out by Professor PGN, and for us to achieve success, we need a lot of support from the guests who are over here, as well as from the faculty who is here, and I guess all the peers who are over here. And I'm looking for a wholehearted support from all of you. And thank you for being here today.
Thank you, sir, for those insightful words and your leadership that led to the building of this center. To officially inaugurate the center, I now invite Dr. Reddy along with all dignitaries to unveil the plaque and mark this important moment.
Sir, a request, Srini sir, Ajit sir, RC sir, Beaver Garu, please come. So before we wrap up, Srini Garu, we want you, on behalf of the Institute, and give your reflections for us, sir, guidance for us for this center. He's been a key architect behind this, sir. The reason this happened is Srini sir's push.
Thank you. I just don't want to hold much. We are very happy that we have, our big brother here, Nageshwar Reddy, what they have actually done in this city, especially, that, is being such a big figure in the world. Whenever they have functions there, they invite me. I don't miss those things there. I meet the incredible people. He brings them across the world, all these Nobel laureates kind of people. So that's when we got the inspiration that, we had to work very closely with the AIG. And normally you don't, in Indian hospital system, we do not find the, kind of people like, who are very research oriented. And one day he invited all of us, we were sitting there, and each of their heads of the department and came made presentation. I mean, wonderful. It's not just they're just good doctors, but they also, he trained them to be good presenters, people who could actually articulate things very well. So I think that's a very special thing about AIG. And we don't see that in other places. And as we got the inspiration from there, we were, our faculty here, as you heard, that research-wise, they have been really doing good work, AI, ML, and computer vision. At least in the Indian context, they're recognized across the world from India. So the issue has been that they do a lot of work, and the outcome of that may come many years down the line. We don't know yet. So for Indian situation, we have problems today. We want to solve problems from 10, 20 years from today. That's far away kind of thing. We need to. That's the reason why I've been pushing with PJ and saying that whatever I support here, let's focus on today's problems and the problems that'll help the populations. First we help in India, then it'll help the other places also. So we would like to take up few large things with you. We'll also go and raise the money from other sources also. It's not that it will be limited with a little bit of money that I'm giving, but we really want this thing to evolve into where probably we have $100 million budget every year kind of thing. It's not that. That's a level of thing that we need to move in. And today, Government of India does support us. And they do give the matching grants, or sometimes they're willing to support it, just that we have to show them the results, that the effort that we make it here. While it is located in IIIT, our intention is that to work with many other people across the thing, wherever they're the best of the faculty in IITs or wherever it is, that the aspiration is that can we make this thing as a leading institution that will build solutions for our nation and others. We thank you very much. Your presentation was fabulous, has always been there. So thank you all, Mohan Reddy Garu. And you asked one question, how did this idea came in, this independent thing? I didn't know that today he's going to come in. He's the one who gave that idea, said it should not be government, it should not be private, it's a public institution. That was his thought process which created this model. Okay. So Chandrasekhar Garu, thank you for having brought us together 25 years ago, 26 years ago. And he's the reason that I'm here then and today, that he made me to sign the first the incorporation document. So I did not know what I was doing, but he did say that you signed, because I was there that day with him. So that emotional feeling of being one of the founding signatories of this institution, I continue to be here. I really enjoy to be here. Thank you all for giving, and thank you all the faculty and the students who have been supportive of it. Thank you.
Thank you, sir. So we're just going down to the exhibition room, sir. We'll have the snacks there. Sir, if you don't mind, we'll trouble you for a few more minutes. There's some media that wants to talk to you. Online, national media. So we'll do.
Thank you, sir, Dr. Reddy, for gracing this occasion with your presence. As we celebrate